Welcome to the Surgery and Therapy Summit interview with Dr. Dirk van der Spuy. Dr. van der Spuy, thank you so much for joining us so that we can find out a little bit more about you.
Thank you, Robyn. It's a great privilege, and I'm very excited about the summit. And I think this is beyond what has happened before in at least in the circles of surgeons and therapists together. And thanks for bringing us together in the summit.
It's a pleasure. Well, my vision for the summit was for surgeons like yourself to share your surgical experience and techniques with your colleagues and with therapists, because we also need to have the detail in order to be efficient and effective in our practice, but more so for your colleagues, because every surgeon spends so much time operating and perfecting their skill and researching and learning and also having a variety of patients. And often when we go to conference, you find surgeons will do a presentation and you'll look at this and go, wow, those are fantastic outcomes. But the question is often, how did he do that? What were the little decisions that he made that are so valuable? So I'm really, really honored that you will be performing a procedure for us at the summit. So before we talk about that, tell us a little bit about yourself. What brought you to becoming a hand surgeon?
It's interesting. Some patients ask why, how can you be a hand surgeon? Is there enough procedures to do just on the hand? But the hand fascinated me from varsity days. I had sort of found the anatomy very challenging beyond any other parts of the body. So I think there was that kind of a stimulus that, if the challenge was up there to say, can I master this? And so I think that fascinated me. And I always wanted to become an orthopedic surgeon. And even before I wanted to do medicine kind of thing. So there was this fascination with one part of the limb, which I found was sort of the most intricate and very beyond what we can understand from it. So I guess, and then as my registrar times as an orthopedic surgeon sort of carried on, I realized there's a plastic surgeon in me, and I like the reconstructive parts of it, and that's one of the reasons I also went to Sydney, just to go and learn more about plastic reconstructive piece of hands, which is essentially just as important as the orthopedic piece, and really trying to marry these two specialities. And I think that's where hand surgery meets us, is reconstruction, and I thoroughly enjoy all the bone reconstruction work as well. But hands is the merge. And it's probably, and I still think, looking at the other specialities, it's probably one of the only creative surgical specialities where really creativity still plays a part in the outcome. And I'm always curious.
Absolutely. It's the creativity, it's the art, it's the science, it's everything coming together. And then for me, it's about the patient. I just love the fact that my patients are fit well. Often they're sportsmen. They're coming to us and they need us to fix this part of them so that they can get on with their lives. And that's so rewarding. And
yeah,
so
absolutely. So just on that, I do think that is a very important part for me as well. We're working up a patient profile need their hands, and I think it's very rewarding. We're obviously working with sick people to some extent, but for the arthritic or the fractured hand that couldn't do anything, and especially with your therapist as well, like guiding them through this process, seeing them thrive again is probably the most rewarding thing, I think, in medicine. And it makes therapy and all the effort worth it in the end.
Absolutely. It reminds me of a patient of mine who was, ironically, this is what we're talking about today, but she was shot through her CMC joint in a attempted hijacking. And I rehabilitated her. And then at the end of her therapy, she walked in with this magnificent charcoal drawing of these two hands. And signed it as healing hands. And she just said, I'm so grateful that you gave me my hands back. And I didn't even know she was an artist. And I think it's exactly that, we sending them back into their lives, and without that the correct intervention at the right time, they may never be able to do the things that they love. So
absolutely, and that's why it's I think also for the summit is really connecting with the therapist. I think it's a very important part in hands. Well, in the management of hands is to bring together, and I think the whole conceptually if we can narrow that bridge, we can get better outcome as well. So well done for doing this whole thing.
Oh, it's a pleasure. Thank you. So tell us a little bit about your time in Sydney. How long were you there for?
So I did a year fellowship in Sydney, the Royal North Shore Hospital, and Professor Tonkin is one of the world experts on congenital hand surgery. So I specifically went there to further my skill in that. I think it's relatively poorly trained in the South African non-specialized hand surgical training platforms, and then also peripheral nerve reconstruction, and as I said, not only the congenital but the peripheral nerve surgery, brachial plexus, and plastic reconstructive parts were very well taught there. So very all-round great fellowship. Can recommend it to anyone. Sydney is quite fun. I think it's a good year. It's nice to be back though. I always knew I want to be come back to Cape Town.
It's a close second to, in fact, probably even ahead of Sydney in terms of beauty.
Absolutely, yeah.
We have the mountain. That's wonderful. So, okay, so you work in private practice, and you work in Cape Town, but you also have a practice in Windhoek, which is in Namibia.
Yes, so this is sort of something that started organic about 10 years ago. My good friend that trained with me, Dirk, is a foot surgeon, and he just kept, had a collection of a couple of hand-related patients that he wanted me to come and see, and that then just organically and slowly grew into a very rewarding practice. Namibia is a land of people working hard. It's a tough country to survive in, so the people have to work very hard with their hands in the land, in the sand, in order to make a living. I like that idea, and I like Africa, and I like the people, and it's a very it's kind of an honor to work there, and it also attracts some of the other African countries' patients, and so the degree of pathology there is interesting, and you see a lot of things that we just never see in South Africa, which makes it worth going.
How lovely. And as you say, you've got the desert right on your doorstep, so you can get to enjoy that. Do you take a little bit of time for yourself, or you just all work?
Yeah, we try to do some family trips try and get my girls up there sometime. We have done a couple of camping trips, and then there's definitely as Sausage Flow is the favorite place in the world, the desert. So I'd like to make trips. I've got a few on my bucket list still to do, but time is a factor because there's very long distance traveling there. So time is unfortunately for this part of our life, makes it difficult to go and reach the corners of Namibia. But I will certainly do that.
They'll get there. And you're also an entrepreneur. You fascinate me in that realm because it's something I'm passionate about. Tell us a little bit about the other businesses that you have.
So I find it very difficult when I came back from Sydney to start in private practice. There are a lot of components in private practice that is essentially running a business, and you would know from running your hand practice, all the components of a business has to be there, everything from marketing, business registration, all the way through to your collection models, and ultimately you must make the place looks nice. So and those pieces were just not together, and so I asked around, nobody could really help me, so we had to extract different pieces, and then eventually we started the company called iMedprac, which is sort of geared to a complete practice management solution, helping new specialists to set up, and also helping those that's been just plateaued and needed some refreshment. And we've been doing it for the last 9 years. It's been a fantastic journey, and out of that grew our practice management software called Astrocyte, the software that connects, which is a complete practice management solution that connects, or it's a digital solution. So in other words, mobile first, but it entails the whole practice management that you need everything from the digital records and the complete booking system with a complete financial solution, which is a challenge in South Africa, as we've got a very complicated private medical system with about 80 funders. So it's been a great journey. The product's being in development, but it's rolled out and it makes my life very easy. And even if I just did this to make my life easy, it will still be worth it. And one day I'll learn to code and then I'll do it myself.
You'll be able to do all your own updates.
Exactly.
That's wonderful, because none of us are taught business at university. We're not taught accounting. We're not taught all of that. So, and it's a self-learning journey. And I think that some practices are run more efficiently than others. And ultimately, at the end of the day, it needs to be profitable.
Absolutely. We've recently done a CPD accredited practice management 101, sort of almost 18 talks on how to set up your practice, and everything from clinical notes keeping all the way through the ethical pieces, medical legal stuff, etc. So and I've learned a lot through that, creating all the content for it. But yes, we are bad business men and women, principally because we are much more sort of focused on the wellness of human beings, but ultimately you have to work and create. You have to put bread on the table. So if you can combine that, that's where the happy place is in.
Well, you will enjoy Dr. Donald Kramer's panel discussion with Phil Ayres at the summit, and he basically is talking to us and teaching us about the little nuances of how to market one's practice effectively and where to put one's digital marketing spend, because that is something that we also need to pay attention to. But there are also a lot of interesting facts, so look out for that talk. I think
I'm looking forward to it.
Yeah. And what is wonderful is, I think what's going to evolve from the summit is a community. Well, everybody who attends, we can all learn from each other and access each other's products, because really that's what it is at the end of the day. It's about collaboration in order to improve our knowledge as well as our efficiency and effectiveness. So well done.
Well, thanks. Well, thanks for creating a platform that we can do these things in.
Yeah, I think it will be good. So now, in terms of the operation, tell us what you're going to be demonstrating to us.
So I will do the trapeziectomy. So starting with the profile patient is usually the 50, 60-year-old, or probably more older, with full-grade CMC arthritis, and usually associated with some parts of STT arthritis. So this is the patient with severe base of thumb pain, crepitus, very sore. And basically what I do for these patients is a complete trapeziectomy. There's some parts in the world where they do hemitrapeziectomies, but a full trapeziectomy, so clearing out the joint space nicely, and removing all especially the medial osteophytes, and then do a reconstruction with a tightrope, the ligament reconstructive part. So in other words, it's the fancy word would be a suspension arthroplasty, meaning you're suspending the first metacarpal in reconstructing the beak ligament. So that's the ligament between the first and second metacarpal. And that ligament is really the regulator of all movement. And it's actually thought that the basis of the arthritis might be because that ligament wears out, and that the joint then subluxes, and then there's secondary osteoarthritis just as a result, as there is the surfaces doesn't align neat, it subluxes slightly and you get what's called point loading, and then the rest of the arthritis ensues. So trapeziectomies, it's I think it's a very good procedure, but of all the procedures I've done in the last 10 years, I found that speaking about perfection, it is a very difficult procedure to get right, to balance the tension, and also to get a good outcome. And this is the absolute quintessential intervention and not even necessarily the trapeziectomy, but the intervention on the CMC, where there's the surgical intervention is so dependent on the post-operative rehabilitation. And once that goes into perfect sync, I think you get a good result. You know, we've given a lot of operations good or bad names just because we, as surgeons, I can say it so clearly because our technique is not fantastic. And we can always get things better. So this is a procedure I feel passionate about because I do feel it's cost efficient, time efficient, and patients do well. I think there's definitely a place for the replacements, and I'm looking very forward to that's going to be part of it, because I think there's definitely a shift towards that as well. But I do think there's a big population still where for the trapeziectomies, I've got variations of it for earlier grades of arthritis, where I believe the instability, where there's instability with early arthritis. And I think those could be salvaged with stabilization first before any arthroplasty or excision arthroplasty.
And what do you instruct your hand therapists to do post-op? What is your protocol?
So, look, I'm fairly aggressive with my mobilization. And when I give you the regime, you'll probably think, some therapists might think that is conservative. But so generally, I mentioned, I think it's important, we've just briefly spoken about the alternatives, which is the KYs. So essentially, the trapeziectomies could be paired with a interposition of a tendon. It could be the APL, it could be the palmaris longus. The Burton Pellegrini stabilizes the CMC joint of the trapeziectomy using variation of the FCR, or in some use the APL. And then there's obviously, so the reconstructive part here is just with the tightrope. So there's no tendon graft morbidity, I think, which is important. So small incision, quick surgery, day case. I put a little splint on post-operatively. They keep it dry for 10 days. Then the therapists take them out in a hand-based splint after 10 days. And I start moving them here from week 2 to 3 and out of the splint by week 5 to 6. And most of them might need a little bit of anti-inflammatories around the 5 to 6 weeks period if they're still very red and swollen. Some react a little bit slow, but I do think early mobilization is important. And I quite like that. It's a big operation. It's a relatively painful operation. So I like things to cool down for the first 10 days and then do a wound check, and then therapists put the splints on. I don't know if you want to comment on that.
It sounds like the right protocol, and I think, you know, there's no rush. I think we need to give that tissue a chance to recover. I think
that's a very important principle. Yeah, there's no rush. You've had it for many years, so give it time to settle.
Yeah, give it time, and often you need to hold the patient back because they just rush. So, okay, before you started using the tightrope, what was your preferred method of the ones that you listed?
Yeah, so we were raised with when I was orthopedic registrar, and it's not sort of 2010. We were raised with trapeziectomies, and then the tightrope just sort of came about, and I sort of remember at the end of my training we start using them, and quickly learned that it's a technical procedure, and many people give up on it because you can really get it wrong. I mean, if you make it a tightrope, then patients can't move. So tightrope is the wrong word. I call it sort of a balance rope. Tightrope is probably the wrong. But we used Burton Pellegrini's before, and I remember when I was in Australia, we worked with different consultants. There was probably 5 different ways that people do the weaving in the tunnels and things. So I got so confused with what the correct way of the original Burton Pellegrini was, but it didn't matter because ultimately the principle is it needs to be suspended in a very specifically in the original anatomical position that allows normal movement. The problem, so we were raised with what was called excision suspension arthroplasty, because that just means that you reconstruct the joint with a tendon. But I've revised a lot of those with subsidence. So in other words, the metacarpal drop down as the tissue become insufficient, and they sub onto the scaphoid, and then they go in an adducted position, and then we get the hyperlax MCP joint, which is the Z-type deformity, and those are very difficult to manage, I find. And when I revise them, I try to do a contraction release, get the MCP or the CMC joint in the right position, tightrope it, and then address the MCP, especially in these old 80-year-olds with very lax MCPs. I sometimes just put a KY across just for a period, just for the ligaments to stabilize.
I think that's brilliant, because, as you say, it can be very, very tricky. And in your experience, because you said you've been doing these for about 10 years now, so you're finding that they've got longevity. They're not at all failing. You're not having to do revisions. What would call for a revision?
Yeah, so I think it's a very good question, because when we look at the literature, it's difficult to interpret, because it's important to see where, I mean, the first 3 months, doesn't, if we're going to do a replacement versus the tightrope, and the results is all going to be the same at 2 years, we should do the more cost-efficient one. So to answer your question, the ones that I've revised, so first of all, it's the most wonderful thing if you see a patient coming back 3 or 4 years later. The x-rays don't look great, but they tell you they can't remember which thumb you've operated.
Great.
Because they forget about it, and that's the ultimate goal. So once the view that I see about a successful operation is people regain their strength, the pain is away, and they feel that their life can go on, and they go back to what they were doing. So I've done a couple of tightropes for farmers, men that's working hard, and if they can go back to their activity, that's a win. Yeah. The only one that I've revised that's broken is a farmer that picked up a farm worker 2 months down the line in Namibia. So that things happened there. So he broke the tightrope, and then we had one or two that we revised where it might have been a bit tight. So it's very difficult to gauge. But I must say, in the last 5-6 years, I didn't have to revise anything from a technical point of view. We've learned a lot from especially like bearing the knot on between the second and third metacarpal, and the way of closing the joint, looking very meticulously at the radial nerve that runs past there. So there's a lot of fine attention to detail, and if you get it right, it's a wonderful operation.
Just on the radial nerve, there is a lot of talk and bit of research out there that is saying that some of the pain at the base of the CMC joint can actually come from the superficial branch of the radial nerve. Obviously, your patients are very advanced, needing to go and have a full arthroplasty. But I think for therapists and for patients in the early stages of base of thumb arthritis, it's really useful to lengthen the SBRN using kinesio tape. This is actually a principle I learned from Alison Taylor. And and just the whole way that you can tape that CMC joint can really be very pain relieving for a patient. So I think
I think that is, I mean, just as you say, the radial nerve runs over the CMC joint. It sort of in advanced arthritic cases does get a little bit scarred down as it runs over the APL. And so for me, the first part of the operation is very important. I go and find it proximal and find it distal, and I do a neuroplasty. So neurolysis, and then a neuroplasty into the fat of sort of the globular part of on the volar side, because there is a layer of fat, and there's a lot of complications because surgeons don't always consider that. So it's an important part, attention to detail. So also post-operatively, it's very easy to suture that, especially in thin skin, to suture that in. And I've seen a couple I've revised some neuromas that I've seen that comes as a result of CMC surgery. But yeah, and I always warn the patients that it's going to feel a little bit numb post-operatively. Also, the splints, the CMC type splints in the very thin patients does irritate the radial nerve. But yeah, the radial nerve is a very intimate part of that joint, and you must take meticulous care to protect it during surgery.
I actually have a picture on my laptop of the anatomy of the nerve, like a cadaver hand, and I show that to patients. And I find that that is really useful, because if they understand the anatomy and also see where those nerves are, and you can teach them the techniques to kind of, you know, the scraping techniques and the kinesiotaping techniques, you can really help them a lot. The other thing that I just want to mention from a therapy perspective, and I was very fortunate many years ago to learn Judy Kolditz's technique for splinting the CMC joint. And so I still see so many therapists immobilize the MP joint, and it is completely unnecessary. And I think it's just a nice moment to talk about it. Judy Kolditz described the first metacarpal, and you've got your 16 ligaments around the thumb, and you've also got your hypothena eminence. And she was saying that it actually forms it's like hydraulic pressure around that metacarpal with the forces. And the moment you have that subluxation of the CMC joint, the direction of forces are altered. And that is what causes the pain during pinch. So if you just reposition it and recreate that hydraulic pressure around the CMC joint, freeing the MP joint, you almost position it, and there's no wearing schedule. They can wear it day and night. So for those that are waiting for a procedure or kind of considering whether they should or shouldn't have the procedure, I find that to be a really good splint. And people can go and look at Judy Kolditz's website, Brace Lab, and they can go and look for that article, and it describes exactly how to make that splint. And so,
Robyn, I couldn't agree more with that, and I do think it's important, especially in the early phases of arthritis, to always give the patients a trial of conservative treatment first. And it is so amazing. I mean, you describe it so beautiful. I can't explain. The therapists are much better explaining things to patients. But what you essentially are doing when you're doing that, and you've showed it so nicely with your hand, is when you put it in that position, you reduce the subluxation. So you take the point loading of the arthritic part, which is in the sublux position, and when you bring it forward in the correct anatomical 45 palmar abduction and 45 radial abduction, when you get it in that position, the saddle joint sits equally with essentially with no point loading. And that's what you achieve with the tightrope as well. So exactly what you've done, that position, I hold it in that position, and then I tighten the tightrope, because that is the golden position for reduction. So I think and I agree, the MP joint should be free. There's no point in including it.
The only time I add like a little slip or like a little lip over, add a little piece on, is when there's a subluxation at the MP joint. You just add this tiny piece, and it kind of stops it subluxing, and yet there's still full range of motion. So, I'm really looking forward to seeing operation. And thank you so much for your time that you've given us today. And I can just say, as a therapist who doesn't have the honor of working with you in Cape Town, but I have received referrals from you in Johannesburg of patients who've come back to Johannesburg. You are incredibly meticulous, and your attention to detail in your post-op notes is so helpful to us as therapists, because we then know exactly what you've done. So thank you for taking the time to do that. We don't always have.
It's a pleasure, and good luck with the preparation.
Thank you.
It's a great honor for me to be part of this.
Super. Thank you so much.